Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm that has more than 40 years' experience serving clients in the healthcare industry nationwide.
Today, on Diagnosing Healthcare, we discuss the two final rules published by the Centers for Medicare and Medicaid Services and the Office of Inspector General of the Department of Health and Human Services that present significant changes to the regulatory framework of the Federal Physician Self-Referral Law, commonly referred to as the Stark Law, and the Federal Healthcare Program's Anti-Kickback Statute, or AKS. Hello and welcome. I'm your host, Paulina Grabczak. I'm an attorney in Epstein Becker Green's healthcare and life sciences practice based out of Newark, New Jersey. On November 20th, 2020, OIG and CMS published the long-awaited companion final rules, culminating their efforts in the regulatory sprint to coordinated care. Healthcare companies, hospitals, and providers have been waiting a very long time for meaningful revisions to the rules, which now allow for more flexibilities and hopefully will promote value-based care. There is a lot to unpack here, and we can't cover everything regarding the final rules on one podcast. So on today's show, we're going to focus on giving an overview of value-based rules, as well as pointing out key issues healthcare companies should carefully consider as they take advantage of these value-based safe harbors and exceptions. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. We have three guests joining our discussion today. Jennifer Michael is a member of the firm in the healthcare and life sciences practice in the Washington, D.C. office of Epstein Becker Green. Jennifer previously served as a chief of the industry guidance branch at the U.S. Department of Health and Human Services, Office of Counsel to the Inspector General. In that role, she led a team of attorneys responsible for interpreting and applying federal fraud and abuse statutes to a wide variety of arrangements across all segments of the healthcare industry. And she now advises clients in this area. Jennifer, thanks for joining us.
Thanks for having me, Paulina.
Next, we have Anjali Downs, who is a member of the firm in the healthcare and life sciences practice in the Washington, D.C. office of Epstein Becker Green. She counsels a variety of healthcare and life science organizations on fraud and abuse and federal and state regulatory compliance, including internal investigations relating to anti-kickback, self-referral, billing and coding, licensure, exclusion, and false claims issues. Anjali, welcome to the show.
Thank you, Paulina. I'm happy to be here.
And Lesley Yeung, who is a member of the firm in the healthcare and life sciences practice, also in the Washington, D.C. office of Epstein Becker Green. She advises healthcare providers with government investigations relating to healthcare fraud and abuse arising under anti-kickback laws, the Stark Law, and the False Claims Act. Lesley, happy to have you here today.
Thanks so much, Paulina. Thanks for inviting me.
Let's jump in. As mentioned, today's show will focus on the value-based exceptions and safe harbors. We want to note that there were other changes to the Anti-Kickback Statute and the Stark Law that were included in the new rules, but that we do not address today.
So, Paulina, before we delve into the details of the various exceptions and safe harbors and talk about the differences between them, I think it's important for our listeners to know that both new rules encourage parties to assume more financial risk by offering more flexibilities as parties take on more risk. And the thinking here is that if providers are being paid for value and taking on financial risk for outcomes and cost overruns, the government can have a much lighter touch and loosen the reins a little bit.
Understood. I really appreciate that point, of course. So, Anjali, we know that there are three new exceptions for remuneration provided pursuant to value-based arrangements between a value-based enterprise and one or more value-based enterprise participants. Can you discuss this new exception for value-based arrangements that meet certain requirements?
Sure, Paulina. But before diving into the exception, we really have to start with some of the key terms that are consistently used both between the AKS safe harbor and the Stark Law exceptions. The overarching question really is, what is a value-based arrangement? A value-based arrangement is an arrangement for the provision of at least one value-based activity for a target patient population to achieve a value-based purpose to which the only parties are the value-based enterprise and one or more of its VBE participants, or VBE participants in the same value-based enterprise. That is quite a mouthful. What we're really talking about is, who are the parties? What are they trying to accomplish? For whom and how? So Jennifer and Lesley, can you help me break these definitions down?
Sure. Let's start with value-based enterprise and VBE participant. And when you think about identifying those, the question is, who are the parties to the value-based arrangement? VBE participant means the individual or entity that is participating in the value-based arrangement. Value-based enterprise, or VBE, is the collection of individual VBE participants.
Great. So next, I'm going to talk about the definition of a target patient population, which really focuses on which patients are going to benefit from the value-based arrangement. So the target patient population must be identified by the VBE or a VBE participant using legitimate and verifiable criteria. Those could include a patient's disease state or condition, geographic areas, income, age, those types of criteria. They must be set out in writing in advance of the start of the value-based arrangement. And the selection of the target patient population using the criteria must further the VBE's value-based purpose.
Value-based activities. So when you think about that, think about, what are the parties committing to do? A value-based activity can mean providing an item or service, taking an action, or refraining from taking an action. Value-based activities do not, however, include making a referral.
So then the last definition is value-based purpose, which focuses on why these entities want to do the value-based activities that Jennifer just described. A value-based purpose can fit within one of four defined goals. The first is coordinating and managing the care of a target patient population. Second would be improving the quality of care for a target patient population. Third, appropriately reducing payers' costs or their growth in expenditures without reducing the quality of care for a target patient population. And then the fourth goal is transitioning from healthcare delivery mechanisms based on the volume of items and services provided to mechanisms that are based on the quality of care and controlling the cost of care for a target patient population. Importantly, one of these four goals must serve as the basis for each of the activities being undertaken as part of the value-based arrangement. So you'll hear all of us refer to these various terms throughout the podcast, and hopefully we've explained to you what they mean. And now we'll turn it back to Anjali to answer the first question of, tell us about the first exception.
Thank you, Lesley. The first exception is the exception for value-based arrangements that meet certain requirements. It is a very broad exception, and it's likely to be used by the largest number of entities, regardless of risk, size, and sophistication. It is what we are calling the catch-all exception. It can protect any remuneration, including cash, to a physician, as long as it fits within the value-based framework. But in order to take advantage of the exception, there are certain requirements and safeguards that must be met. And so some of those are technical in nature and really akin to the traditional Stark requirements that we've seen before. The arrangement has to be in writing and it has to be commercially reasonable. But even within those kind of traditional requirements, there is more specificity. So for example, the writing must specify the value-based activities undertaken, how those activities will further the value-based purpose. The writing must identify the target patient population and the type and nature of the remuneration, and it must include a description of the methodology used to determine the remuneration. In addition, the writing must also provide details about the objective outcome measures that will be used. And those outcome measures must be measurable and based on clinical evidence or credible medical support. So a key takeaway for this exception is that there are many tracking, measurement, and documentation requirements that will help to support the value-based purpose, but will also help in determining whether or not the arrangement is successful. So parties are going to have to continuously monitor whether the value-based activities are actually happening, and then determine if there's progress towards achieving the outcome measurements. And if not, determine whether or not to continue the activity, and if continuing that activity will help to further the value-based purpose. So while success or actual achievement of the value-based purpose isn't mandatory, it seems to me that if parties identify through this continuous monitoring element that the activity may not be effective, then they are going to have to evaluate whether or not they need to modify or terminate the activity to avoid liability. And so I think this monitoring element is really important and should not be overlooked. If you kind of look at this arrangement as a set it and forget it, and then if the activities are no longer supporting the value-based goal, that could lead to potential remuneration that isn't protected by the Stark Law. And what I'm struck by is that this type of ongoing monitoring and adjustment isn't as familiar to us in the Stark Law context, where we've really come to expect that kind of bright line rule that applies to the strict liability Stark Law.
Very good. Okay. Lesley, can you describe the exception for value-based arrangements when there is meaningful downside financial risk to the physician?
Sure, Paulina. This second exception here is meant to recognize that all physicians are not necessarily prepared to take on full financial risk for the total cost of care for a patient population. But they want to move towards value-based arrangements. They want to move beyond what Anjali was just talking about and participate in alternative payment models that require the undertaking of some downside financial risk. So, get their feet wet a little bit, I guess, if you will. By taking on some level of financial risk that's tied to achieving the value-based purpose of the arrangement, CMS is willing to loosen up the guardrails a bit compared to what's required for value-based arrangements, as Anjali just described. So this is sort of the middle ground, and I'm going to talk a little bit about what meaningful means and how do these arrangements need to be structured to meet this exception. First, it's important to note here that under this exception, it's the physician, not the value-based enterprise, that's supposed to be taking on the financial risk. So we need to focus on the physician here. And a physician assumes meaningful downside financial risk if the physician must repay or forego at least 10% of the total value of the remuneration. So that could be monetary and non-monetary remuneration, in-kind contributions, as Anjali was just talking about, related to infrastructure or care coordination costs. So it's the total value that the physician is eligible to receive for successful completion of the value-based activities under the arrangement. The physician's assumption of risk could be structured in a variety of ways. So things like withholding of compensation, required repayments, or the ability to receive an incentive payment. Those could all be indicative of the assumption of risk for the physician. Additional guardrails under this exception include making sure that the nature and extent of the physician's downside financial risk is put in writing. And the methodology used to determine the amount of remuneration must also be set out in advance before the physician undertakes any value-based activities. There's no explicit requirement that the VBE must monitor the achievement of the value-based purpose, but it seems to be implicit in the requirement that the physician has to be at risk, and the risk is related to failure to achieve the value-based purpose of the arrangement. So, Paulina, what do you think? Does that make sense?
It sure does. It sure does. And I think a lot of us will be digesting and reading this for quite some time. So we'll be unpacking this for years, I'm sure. Anjali, can you describe the exception for value-based arrangements when there is full financial risk? We know that the two elements here are the degree of financial risk and how the remuneration is structured.
That's right, Paulina. So whereas the first exception I described is broadly available, this exception is likely to have much more limited utility. And that is because the value-based enterprise within which the remuneration is being paid must be at full financial risk during the entire arrangement, or at least contractually obligated to be at full financial risk within 12 months of the beginning of the arrangement. So what that means is that the value-based enterprise has to be financially responsible on a prospective basis. So prior to providing any patient care items or services, the value-based enterprise must be financially responsible for the cost of all patient care items and services covered by a payer for the patients in the target patient population. So realistically, for Medicare patients, that means that the VBE would have to be responsible for all items and services covered under Medicare Part A and Part B for that population. That is a really heavy lift. Paulina, as you said, the second element relates to the structure of the remuneration. And the remuneration must be for value-based activities undertaken by the physician for the target patient population, and it cannot be to limit or reduce medically necessary services or be conditioned on referrals of patients who are not part of the value-based arrangement. As with some of the other value-based exceptions, the remuneration here can be conditioned on the physician's referrals to a particular provider, but that must be set out in writing, and the best interest of the patient and the patient preference, including the patient's insurance, should also be considered.
Thank you. So we know that the AKS was also modified to provide 3 value-based safe harbors. Although these changes are similar, there are several differences. Jennifer, why is that the case?
So as we know, the Stark Law is a strict liability statute, which means that when an arrangement implicates the law, an exception must be satisfied to avoid liability. In contrast, the Anti-Kickback Statute is a criminal intent-based statute, and compliance with a safe harbor is voluntary. The differences in these two statutes led CMS and OIG to create intentional differences in the value-based safe harbors and exceptions, with CMS creating broader exceptions to account for the Stark Law's strict liability standard, and with OIG taking a narrower approach so that the anti-kickback statute can serve as backstop protection against abusive arrangements.
Thank you. I think that certainly provided a great explanation of why they are similar, but differences still certainly remain. Jennifer, let's talk more about this. Let's dive into those 3 value-based safe harbors. What are they? And can you speak more about how they compare to the Stark changes?
Sure. So OIG promulgated 3 new safe harbors for value-based arrangements. Like the Stark Law exceptions, the value-based safe harbors provide increasing flexibilities as parties take on more financial risk. The first of the 3 safe harbors is the Care Coordination Arrangement Safe Harbor. And this safe harbor protects in-kind remuneration exchanged between a VBE and a VBE participant, or between VBE participants, regardless of whether the entities assume any financial risk. So think of this as the entry-level value-based arrangement safe harbor. And examples of arrangements that could be protected under this safe harbor include agreements between hospitals and SNFs to provide a care coordination manager to assist patients transitioning between settings, or an arrangement between a hospital and a physician group to provide data analytics and remote patient monitoring technology to help the physicians monitor and ensure that their patients are achieving better health outcomes. Of course, those are only 2 examples. There are many types of arrangements that could be protected. This safe harbor has 13 requirements, and some of those requirements have sub-requirements, and it also excludes certain entities from protection. So listeners, please stick with us. I'm not going to walk through every requirement, but I do want to hit on some of the more important ones. First, the remuneration, which remember under this safe harbor must be in kind, must be used predominantly to engage in value-based activities that are directly connected to the coordination and management of care for the target patient population. Now, you'll remember that Lesley walked us through the 4 qualifying value-based purposes that can be protected under these safe harbors. But to receive protection under this particular safe harbor, at least one value-based purpose must be the coordination and management of care for the target patient population. The remuneration must not be used for marketing or patient recruitment purposes, and it must not be exchanged by an ineligible entity. And those ineligible entities are pharmaceutical companies, laboratories, PBMs, compounding pharmacies, DMEPOS, and medical device companies. There is, however, one exception to this carve-out for DMEPOS and medical device companies that exchange digital health technology with another VBE participant. And that term digital health technology is broadly defined to include hardware, software, and certain other services, and it also includes associated internet or other connectivity services. Second, and this is an unpopular one, the VBE participant receiving the in-kind remuneration must contribute at least 15% of the cost or fair market value of the remuneration. And if you're thinking that that contribution percentage sounds familiar, you're right. It is the same contribution percentage as is found in the EHR safe harbor. Third, you'll see many of the typical safe harbor requirements, including that the value-based arrangement must be in writing and must be commercially reasonable, both individually and in the aggregate, and it must not induce VBE participants to stint on care, to limit medical decision-making, or to limit patient freedom of choice. So there's no fair market value requirement here, but the combination of that commercial reasonableness requirement and that 15% contribution requirement, I think ends up having a similar impact as a fair market value requirement might have. And finally, the parties to the value-based arrangement must establish one or more legitimate outcome or process measures that the parties reasonably anticipate will advance the coordination and management of care of the target patient population. And those outcome measures, like under the Stark Law, must be based on clinical evidence or credible medical or health sciences support. And here they cannot be based solely on patient satisfaction or convenience. The parties to the value-based arrangement must periodically monitor and assess progress toward achieving the outcome measures. And although the parties likewise are not required to actually achieve the value-based purpose, if that purpose is unlikely to be achieved, the parties must terminate the arrangement or develop a corrective action plan.
So with all of that, now I'm going to jump into the next safe harbor for substantial downside financial risk. This safe harbor protects both cash and in-kind remuneration exchanged between a VBE and a VBE participant in cases where the VBE has assumed substantial downside financial risk from an entity, likely a payer, and the VBE participant meaningfully shares in the VBE's substantial downside financial risk. Whew. So there's a lot there in each of these, those two sentences. What does it mean to assume substantial downside financial risk? From the OIG's perspective, the VBE must assume financial risk through a shared savings and losses arrangement, an episode of care arrangement, or partial capitation methodologies. And each of these different methodologies has its own threshold for what is considered substantial downside financial risk. So on the shared savings and losses side, the repayment obligation for the VBE must be at least 30% of shared losses for all items and services covered by the payer and furnished to the target patient population. For episode of care arrangements, the repayment obligation must be at least 20% of total losses for all items and services collectively furnished in more than one setting through an episode of care. And then for the partial capitation methodology, the VBE's payment must be made prospectively on a monthly, quarterly, or annual basis for a predefined set of items and services that are furnished to the target patient population. In addition, as I said before, the VBE participant must meaningfully share in the VBE's substantial downside financial risk. And that means that the VBE participant must assume two-sided risk for at least 5% of the losses and savings. This is an interesting one because this assumes that if each VBE participant must be at risk for at least 5%, is there a cap of 20 VBE participants in any VBE? Alternatively, under a partial capitation arrangement, the VBE participant must receive a prospective per patient payment on a monthly, quarterly, or annual basis from the VBE for a predefined set of items and services under a partial capitation arrangement. The VBE participant can't be separately submitting claims for payment from the payer for the predefined items or services covered by the partial capitated payment. The remuneration between the VBE and the VBE participant must be directly connected to one or more of the value-based purposes. So again, this goes back to that important definition we talked about at the beginning with the 4 goals. The value-based arrangement must be in writing, and it must not induce VBE participants to stint on care, limit medical decision-making, or patient freedom of choice. It can't take into the account value of referrals of patients who are not in the target patient population or business that's generated outside of the value-based arrangement. This safe harbor is not available to ineligible entities that Jennifer went through a little bit. So pharmaceutical companies, labs, PBMs, et cetera. The safe harbor does not protect downstream arrangements among VBE participants, and it also does not protect ownership and investment interests in the VBE or any related distributions to those ownership interests. And similar to the care coordination safe harbor, this safe harbor includes documentation requirements, and it prohibits the use of remuneration for marketing or patient recruitment activities. So Anjali, let me turn it over to you now.
Similar to CMS's full financial risk exception, the Anti-Kickback Statute also has a safe harbor for value-based arrangements with full downside financial risk. This safe harbor protects cash payments and in-kind remuneration between a VBE and a value-based participant where the VBE or the value-based participant, that is someone other than the payer, has assumed full financial risk on a prospective basis for the cost of all items and services covered by the payer for the target patient population. Like the CMS exception, there is a 1-year phase-in period. An example of an arrangement that could qualify for this exception is a contract with a Medicare Advantage organization to receive a fixed per patient per month amount that covers the cost of all items and services furnished by the Medicare Advantage plan for the target patient population. But I think, like the CMS exception, although the safe harbor is less onerous, it is somewhat aspirational because not many entities can take on full financial risk for all services and not be a payer. Jennifer, what do you think?
I totally agree. I think that certain IPA type arrangements may qualify. For example, where an IPA takes on full financial risk from a payer, typically for a percentage of the premium payment the payer receives. But one thing to remember is that the transfer of insurance risk from a licensed insurer or HMO to an unlicensed entity is governed by state law and not by OIG or CMS. And so the fact that an arrangement may comply with an anti-kickback statute safe harbor does not necessarily mean that it complies with state insurance laws. So you have to be careful and make sure you're complying with all applicable laws.
Thank you all for that. And, one of the things that really jumps out at me as everyone was talking is I realized that care coordination is the only one that does not involve cash in the AKS safe harbor. So that's certainly a very interesting note and takeaway. As everyone can see from today's discussion, these changes to Stark and AKS should provide a necessary step in the right direction for fostering coordinated care by transitioning towards a value-based payment model. However, as with any new regulatory framework, the key is always in the details. From the changes discussed today, what are the best practices or areas that require careful consideration? Jennifer, do you want to kick it off?
One consideration relates to fair market value, and that is how the absence of a fair market value requirement in the exceptions and safe harbors relates to the total compensation and remuneration given pursuant to other arrangements. Although the new safe harbors and exceptions don't require remuneration to be fair market value, you can't view them in a vacuum. You need to think about the aggregate remuneration across all arrangements. And I think how fair market value is analyzed across all arrangements and applied only to the value-based arrangement will continue to be a gray area.
I would jump in to say another thing to remember, and Jennifer already touched on this, is that these new rules apply to the federal Anti-Kickback Statute and the Stark Law. But providers also have to consider that other federal and state laws, like state insurance code or state licensure laws, may apply. So it's really important to be taking those into consideration, as there may be additional limitations on how arrangements can be structured. Additionally, this is another point to take into consideration, and it may not be overly surprising coming from a bunch of lawyers, but it's really important to develop and maintain documentation supporting the facts and circumstances of the value-based arrangements. Even where it may not be explicitly required in the regulations, parties should be thinking about how they are documenting the value-based purposes of the arrangement. What are the parties going to do to achieve those purposes? How is remuneration tied to those purposes? How is success measured and monitored? And if necessary, how does the arrangement need to evolve over time to ensure that the value-based activities and remuneration are still relevant to the stated value-based purposes and goals?
And Lesley, that's even true in the Stark context, where we haven't traditionally thought of a facts and circumstances analysis. And along the same lines of documentation, I think this is going to be a constantly evolving process, which is going to require ongoing planning, implementation, and assessment. Because although successfully achieving the value-based purpose is not required, you will have to continue to monitor the arrangements to determine whether or not you are going to achieve the value-based purpose.
That's right, Anjali. And I'd add that on the flip side, once you have achieved a value-based purpose, it may not be appropriate to continue paying remuneration for that purpose that has already been achieved.
Jennifer, Anjali, and Lesley, thank you so much for joining the discussion today. We certainly really appreciate it. And to our listeners, thank you for joining us. If you like what you hear today, please subscribe to the show. Diagnosing Health Care is available wherever you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.